皆様こんにちは。改めまして私の方からも東日本大震災により犠牲になられました多くの方々のご冥福と、それから被災地の一日も早い復興をお祈りいたします。また本日は被災地の保健府の復興と経験共有ということに関しましてのワークショップを震災からちょうど2年経ちました本日この日に開催する運びとなりました。今回の開催にあたりまして関係者の方々の皆様のご協力に心から感謝申し上げますとともに、また皆様本日ご来場いただきました皆様にも心より御礼を申し上げます。どうもありがとうございます。で震災が起きましてから私ども笹川平和財団でもこの甚大な被害を目の当たりにしながら、私たち財団として何ができるんだろうかということを考え続けてまいりました。で日本財団でありますとか、共同募金会、あるいはジャパンプラットフォームのように、いろいろな民間の方々が募金活動、あるいは緊急支援を続けられている中で、私たちもその努力にも協力をしながら、やはり笹川平和財団という財団で活動している以上、国際的な視野に基づいた活動にもご支援をしたいというふうに考えておりまして、この被災地の保健機能復興と経験共有と題する事業に助成をしてまいりました。でこの事業は東日本大震災の発生直後から2年間にわたりまして、東北大学大学院医学系研究科の地域保健支援センターの先生方が実施されてこられました。で大規模災害によって医療機関や保健医療人材、あるいは保健行政システムが広範囲にわたって壊滅的な打撃を受けたときに、刻々と変わる被災地の状況やニーズを踏まえながら、保健医療や保健行政に携わる方たちが何を考えて、どのように対応していったらよいのかというのが、この事業の問題意識であるというふうに私は理解をしております。またこの事業を進める中で、東北大学の先生方とお話しさせていただく機会の中から、日本の現状においては、保健師という役割の皆様が、いわば司令塔のような役割を果たすことが求められるんだということを私は理解するようになりました。また、今回の特徴として、被災された地域の中で、保健師の方々がご自分の担当される地域の方々の病歴であったり、あるいは家庭環境等もよく理解されていると、そういう状況の中で災害が起こったということも、東北地方の特徴的なことであるというふうにも教えていただいたと思っております。でこれらのことを踏まえまして、WHO で災害支援に長く従事されてこられました玉沢大学に今いらっしゃいますロジャー・ドダン先生、本日はいらっしゃっておりませんが、ドラン先生のご協力を得て、また東北大学においでになります押谷先生も WHO 等で非常に国際機関との関わり、あるいはご経験が長いという中から、この東北地方での経験について、世界的なスタンダードも視野に入れながら、公衆衛生システムの復興ということを詳細に記録をしてこられました。でこの度、この本当に地道な調査活動の結果を素晴らしい報告書と、それから DVD にまとめていただきました。このことに関しまして、心から感謝とお喜びを申し上げます。でこの成果の報告を目的といたしまして、3月の7日、それから8日、この2日間、仙台におきまして、アジア諸国や国内の専門家の方々が一堂に会して、経験や知見の共有を行うシンポジウムが開催されました。で本日はそこでの成果も踏まえまして、保健医療や災害危機管理に携わるより幅広いセクターの皆様にご報告を申し上げるということが目的でございます。そして今後また起こるであろう大規模災害の発生に備えて、どういうことができるかということをご議論していただきたいというふうに考えております。でそういうことで、本日のワークショップでは、まず冒頭に WHO 神戸センターのアート・ペシガン先生より、公衆衛生機能の復興に関して基調講演をいただきます。その後、東北大学の押谷先生、あるいは佐藤先生から、今回の事業の成果報告をいただくことになっております。また、このワークショップの後半では、震災対応の第一線で指揮を執ってこられた 現在、東北大学病院の石井先生にご対応の経験や教訓を共有していただいた上で、それから公衆衛生危機管理の専門家の視点から、国立国際医療研究センターの村上先生、国立保健医療科学院の金谷先生、そして浜松医科大学の小島先生、といったそうそうたる方々からのコメント、そして問題提起をいただき、その後のパネルディスカッション、それから質疑応答というふうに移る予定でございます。参加者の皆様の活発なご議論を期待しております。最後になりますけれども、アジア太平洋諸国では、自然災害の件数や被害が大変増加しておりまして、災害への効果的な対応が域内の最優先の課題となっていると言っても過言ではないかと思います。特に、災害医療分野におきましては、日本からのこれまでは経験や情報の発信がほとんどなかったというふうに理解をしておりますので、そうした観点からも、本事業の成果を特に海外に向けて、継続的に発信していただくというのが重要ではないかと思いますし、そういうことをまた期待をしている次第でございます。最後になりますけれども、本日のワークショップが災害時の公衆衛生システムの復興の改善につながることをお祈りいたしまして、開会のご挨拶とさせていただきます。本日はどうもありがとうございました。
Thank you very much, Fumiko-san, for a very nice introduction. Ms. Junko Chano, Executive Director of the Sasakawa Peace Foundation, Professor Oshitani, Professor Sato, distinguished members of the panel who will be joining us this afternoon. A very pleasant good afternoon to everyone. It gives me a great pleasure to be here. It's also an honor for us from the World Health Organization to be able to share with you some of our thoughts on aspects of recovery from disasters, particularly from the health sector. It's fairly challenging to discuss this topic because amongst the different components of the disaster continuum, recovery is the least interesting for a lot of people, the least funded, the least studied, but it presents various kinds of challenges that we can address. And we are very thankful to the Sasakawa Foundation and also to Tohoku University for inviting us and giving us this opportunity to disseminate more information and for a greater number of people in the health sector to know more about the challenges of recovery, particularly for the health sector. This is just to show us that we are in the context of what has happened here, the Great East Japan earthquake, and it's really fitting that we're here today, this very important day. It's something that we should never forget, and we'll always have to go back and build and make us even stronger as we respond better to emergencies in the future. The global platform for disaster risk reduction is a biannual meeting of the UN. And during its meeting in 2011, one of the notes expressed during the meeting was that the 11 March 2011 earthquake and tsunami in northeastern Japan is a sobering reminder that well-planned actions based on human precision can seem almost extemporaneous when confronted with nature's imprecision. So the challenge is that a lot of things may be unpredictable. We may be prepared and doing a lot of things, but nature can be the equalizer and posing the greatest challenge to all of us. But nevertheless, within that context, we hope that with lessons that we've been learning from emergencies, that we can do better during the recovery process. By definition, here alone, it's probably too general and a little conceptual, perhaps, to all of us. So it's actually for the people who are here that have been to the field, that actually have the taste of what recovery is. But for academics, perhaps, and also for people who make policy, we give some efforts in terms of defining it. So it's said that recovery is a multidimensional process. It aims to create self-sustaining, nationally owned, resilient processes. So this is our aim in the United Nations family, that it should be driven by the countries and the end product should be for resilience, the capacity to be able to bounce better and to bounce back immediately if a disaster happens. So it encompasses restoration of basic services, livelihood, shelter, governance, security, rule of law, environment and social dimensions, and reintegration of displaced populations. So concepts that perhaps are not very, very close to the health sector. But the health sector must realize that we have to work with these other sectors for us to be able to succeed in any recovery process. So this is just a diagram that a lot of efforts are actually done here in the emergency phase. The money is there, the interest is there, the press is there. But if you take a look at the curves, the longest period of time actually would be rehabilitation recovery. But attention has not been really given much here. It's probably because we don't have a lot of experiences for major emergencies wherein we have the serious recovery processes involved. But then again, we have to pay attention as to how we can contribute better to the development process once we undertake reconstruction and recovery activities. So, some key health effects from disasters. One thing that we just want to emphasize is that in a disaster, what is highlighted usually by the public, by the media, would be injuries, deaths, physical aspects, biophysical aspects of the impact on health. But what we have to look into, and we have seen in a lot of our major emergencies, that health would be impacted through mental health and psychosocial issues, food, water safety, communicable diseases, chronic endemic diseases, environmental health issues, immediate reductions in health levels, decline in nutritional status, destruction of health facilities, and loss of personnel supply chains. Now, a lot of these things cannot sometimes be computed in terms of economic impact. That's why perhaps in the health sector that we have a difficult time of communicating the impact of a disaster. But if you're going to see that it encompasses, and the other thing that we always think of is that the failure of interventions in the other sectors are actually, us in the health sector would be at the receiving end. If the failure in food supply is bad, if there is something on the educational system intervention, something on shelter, we will be receiving the end of that, the bad interventions that they would be making. So health is something that is very important, and we always would want to assert that. Now, recovery should be very important for us in the health sector because it gives us a unique chance to reconsider the health sector and to make us have the ability to plan on a more comprehensive and a rational basis. So that's the golden opportunity. Except that the problem that we have is that we're running against time when it comes to recovery too. Now, recovery may give the opportunity of giving large amounts of capital. It would be available, and hopefully from the prefectural level and even to the national and international level. The atmosphere change may reduce resistance aimed at preserving the status quo. So for us who are steeped in health systems reform, this is a golden opportunity for change because people now are perhaps more open because of the recovery phase. And that massive destruction may make the abandonment of unwanted facilities easier. So now is the opportunity for us. But then again, we always have to be careful because that can also be the opportunity that we can make mistakes and actually the facilities that we build are even worse than what they were before the disaster. So for me, I would say that if we're going to look at 4 important issues for recovery, I would go for these 4 key points. And these are the issues of equity, effectiveness, appropriateness, and efficiency. So sometimes we always would want to think of indicators on how recovery would be good. But for me, I think let's just stick down to 4 basic ones. on how we were able to let's say, expand service provision to cover underserved populations. So if we have a good check mark for equity, a good check mark for improving technical contents of healthcare, so that's effectiveness. Adoption of new service delivery models in light of new needs, the appropriateness issue, and increased returns from inputs absorbed by the delivery process, and that's efficiency. So just thinking about these 4 points as our basic indicators, then perhaps we should be in the right track when we are thinking of recovery interventions post-disaster. So we just want to point out again that health is just part of the entire community recovery and reconstruction efforts, and that health is there, and we should always, perhaps the sector should always assert that if money is being put in for these other aspects or sectors, then money should also be invested in health. So as a systems approach, we should consider health in recovery and reconstruction as part of the big system, operating and collaborating with other systems. So it should draw attention to the aspects of how are we building better facilities and infrastructure. It should encompass healthcare resources, financial resources, and human resources. Our panel of discussants will bring out the various experiences on how human resources has been a challenge in terms of recovery. So these are like some conceptual aspects that are in our handouts for your perusal later on. So I won't dwell too much about those. I'd just like to perhaps highlight some experiences we've had in terms of some case studies that we reviewed when we were preparing also as in a similar conference we had last year about looking at urban health systems. And when we looked at some recent emergencies, we were also able to pick up some experiences from these big disasters from 28 to 2011, which includes the Great East Japan earthquake, Christchurch earthquakes in New Zealand, Chile, Bangkok floods, Ketsana, Wenchuan earthquake, Cyclone Nargis in Myanmar, and also the Haiti earthquake in 2010. And what have we learned from some of these disasters, and particularly on the aspect of recovery? So the 2008 Wenchuan or Sichuan earthquake in China, major challenges as they were rebuilding the health system was on, it included information systems revitalization, the early warning system, particularly on surveillance for communicable diseases, and also prevention of infectious diseases like hepatitis A and JAP-B encephalitis. Now, we're just highlighting that to show that for other instances of major emergencies like the cyclone in Myanmar and the Haiti earthquake, it would take a twist in terms of some of the communicable diseases that they have to address. Like in Myanmar, had to look into dengue, and in Haiti, the big issue of cholera. So the lesson here in terms of recovery efforts is that you have to take it also from the context of that particular country and from the context of the nature of the disaster that happened. So we cannot have like a blanket rule in terms of how we approach our interventions in recovery. But then again, what we've seen here in the other emergencies, that what had to be highlighted would be how do we bring back the recovery of the health system. So recovery phase should ensure better access to health and social services, especially for vulnerable groups and people with special chronic illnesses needs, given the language and cultural conditions linked to existing health and referral system and primary care services. And the health sector recovery plan should be linked to the multi-sector recovery plan of that particular setting. Now, what have been some good practices that we've noted in these emergencies? So we have learned from the experience in the Great Hanshin Awaji earthquake in Kobe, and also from the Wenchon earthquake, of the positive contribution of counterpart assistance, that you had cities or prefectures that are twinned to the affected municipalities, and they would be contributing to the development of that health sector for 2 to 3 years. We have also seen, in particular with the Great Hanshin Awaji earthquake, that they emphasized care for vulnerable groups like the elderly and children. The Bangkok floods, financial grants were given to health facilities and hospitals for them to be able to refurbish or reconstruct post-Bangkok City floods. And in Christchurch, what was also emphasized was the need and the positive contribution of community consultation to have a solid recovery plan post-earthquake. Now, Gujarat earthquake, Aceh, Great Hanshin Awaji earthquake, and Christchurch, what contributed also was the establishment of a central authority for recovery that facilitated planning, coordination, and transparency. And there have been very good documentations already about this, on how the central authority or the body was able to help speed up recovery processes. And of course, many countries, post-emergencies, showed that the efforts of having the concept of Building Back Better, BBB, has contributed to increased resilience of these communities post-disaster. From Wenchuan and the Kobe earthquake, build on opportunities to right-size or improve old or inappropriate systems. So from our review of these case studies, we also wanted to pick on certain things that what we should not do again. And from Kobe, delay recovery plan and implementation of the central government was something that we perhaps should not do again. From BAM, the absence of a PDNA, or the post-disaster needs assessment, to help out during the recovery phase of the cities. In Haiti, subsidy of health services by agencies after the earthquake led to difficulty once the services have actually ceased. And this is a little bit complicated in the sense that it would have like implications in terms of like health economics, and also disturbing the private and public relationships, and also the financing of health services post emergency. Now, what not to do again, of course, would be to forget that the community has to be a driving force in recovery planning. That sometimes, if done in an uncoordinated manner, that humanitarian agencies may hijack recovery programs, and that an exit strategy for recovery phase needs to be clear. So in terms of recovery, what perhaps should be priority issues and needs? We've mentioned earlier what not to do is that the absence of a PDNA, and this is an area that perhaps is still weak in the health sector, because there are various tools that have been used for this one, and it has also made economic assessments and evaluation, which of course a lot of the people in the health sector are not too familiar with. But we're trying and putting in efforts in increasing the capacity for doing PDNAs. Of course, countries should have a recovery plan. We should be able to document effective practices and lessons learned to develop a doable, practicable model. The health system and social sector capacity to address the needs of the vulnerable population should be there. This is an opportunity. The things that we have not been able to work on prior to the emergency to address the needs of the vulnerable population should now be addressed. And we have to have mechanisms to ensure continuum of healthcare services for the affected, especially the most vulnerable, undocumented people, and people with special needs like those with TB, HIV, and others should be ensured in interventions. Now, intersectoral links through public health should perhaps be emphasized. The health sector response is integrated into the overall multi-sectoral government response. It should be community-based, bottom-up consultative process. And, of course, the need for training and capacity building for infrastructures and even on the soft aspects of development should be included. Now, we have learned from the case studies like post-tsunami in Sri Lanka, the recovery period was actually an opportunity for them to have been able to review the mental health law. So it revamped the concept of treating mental health patients. So it's also an opportunity for us to be able to review laws that perhaps should be more in tune already to present needs of the country. Existence of policies and legal frameworks to allow local governments, agencies, and partners to engage in the recovery process. Of course, the considerations for funding for recovery and efforts, of course, to avoid competition among various sectors for funding and resources. So I've been here since 2011, and it's provided us opportunity in our center, in the WHO Kobe Center, to interact with a lot of international and national agencies here in Japan when it comes to emergencies. And I've just included here some views of partners from the recent experiences of recovery efforts here in post-GEJE and also internationally. So like the World Bank, late last year during its annual conference, published its knowledge notes, which was called Learning from Mega Disasters. And one of the aspects that they communicated there on recovery planning, that there should be a strong cooperation between communities and local and national governments. The expert group meeting, which was convened by the Cabinet of Japan and also with the International Recovery Platform, it had a meeting in June of 2012 in Sendai and also in January of this year in Kobe. And these are the points that they wanted to raise in recovery. One, strengthen the links between national and local governments. Strengthen capacity and support for recovery planning, specifically at regional, national, and local levels. So what we have to see here would be at the various levels that we have to have efforts in terms of joint planning. The other one is that the use of new communication tools, including social media and open data. A lot of these, of course, were experienced post-GEJE, so we should be able to disseminate information as to how we can maximize the opportunity of using social media. Another aspect, perhaps, that we need to look into in health is that pre-disaster recovery planning as a tool to further reduce risks. So as early as the time that we're doing preparedness planning, that we should already include recovery plans. Monitoring and evaluating recovery by peers. So it's not just like an external agency, but also amongst the groups that are engaged in recovery efforts, that we should be able to have mechanisms of monitoring and evaluating. Other thing that they recommended, that we should now, rather than just issuing policy statements, that we should set clear targets, and that there should be more emphasis on actions at the local governments. And also the role of the international community, that global cooperation systems so that countries affected by disasters can be already assisted at the initial phase of recovery. The International Recovery Platform also, when we had a a forum for the national meeting of the Japanese Association for Disaster Medicine in January. Now, they have said that these are some measures that can be taken by officials to reduce impacts of future disasters on the health sector. And some of them are really talking about safer hospitals, retrofitting old facilities, but they also recommended capacity building. Provide training to medical health workers on disaster procedures and medical health practices. So the other thing that we were doing in our center, the WKC, the WHO Kobe Center, was to look into some experiences in the past, like even dating back to the Hanshin Awaji earthquake. And as early as post-Kobe earthquake, that Hyogo Prefecture utilized mapping by GIS and also registration system to be able to look into the distribution and easy access of the elderly and disabled in disasters. So the use of technology to be able to target specific groups if an emergency would happen in the future. We recently, two Sundays ago, we piloted a new training course which we called City Leadership in Health Innovations and Technologies and Emergencies. We trained city technical officers on leadership concepts and skills. And one thing that came out is that, and a realization from our participants at the city technical officers from the Hyogo Prefecture, is that there is really a need for multi-sectoral collaboration. At the local level, sometimes the local managers would have difficulty in being able to absorb assistance from external groups. And these things perhaps should be done through pre-arranged agreements, or ensuring that training would include that aspect of being able to cooperate and coordinate better with external agencies. Some of our interns were asked to do studies in terms of experiences from Great East Japan earthquake. And our interns looked into the disaster-based hospitals in the affected areas of GEJE. And one of the things that was highlighted was that the disaster-based hospitals would have to perhaps strengthen the aspect of business continuity plans, and perhaps that it should even be included in terms of planning of municipal or even prefectural level health agencies. So overall, perhaps what we would want to look into in terms of health and recovery would be some simple messages perhaps. One, we wish to have safer infrastructures. And when we talk about safer infrastructures, that will be in terms of your structural, non-structural, and the functional aspect. And I think we have to emphasize the functional aspect, that even in times of disasters, that our hospitals should be able to have seamless services delivery. The staff would be there, and the functioning will be all right immediately after an emergency happens. The other one is that for us to be prepared for key public health hazards and future disasters, not just for natural disasters, but even for newly emerging diseases, we should aspire for providing equitable and affordable health services to all, the issue of equity. Furthermore, effectiveness, appropriateness, and efficiency, as I've highlighted earlier, and that the recovery framework should ensure appropriate, sustainable system. So as we discuss recovery from GEJE, the presenters will be dwelling more into that, and also for the panel discussion later, we pose some questions. Like, what are lessons learned that have been applicable from experiences here in Japan, from the great Hanshin Awaji earthquake? other major disasters globally. The second point, what are unique features that would highlight context of emergencies and disasters? And also that public health recovery is truly a reflection of the state of the health system of any country, community, or society. So this is my last slide to quote our Director General of WHO, that the center of all the efforts that we're going to be giving in recovery or any humanitarian effort will always be towards the concern for the disadvantaged and vulnerable groups. With that, I'd like to thank all of you and have a wonderful afternoon. Thank you.